Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McCray.
Tracy, lung cancer is by far the leading cause of cancer death among both men and women in the U.S. Each year, more people die of lung cancer than of colon, breast, and prostate cancer combined. Now, survival rates for lung cancer are better than they've ever been, but the lung cancer 5-year survival rate is still less than 20%. Meaning that less than 1 in 5 people live for 5 years following diagnosis.
Oh.
And more than half of people with lung cancer die within 1 year of diagnosis. Pretty frightening statistics.
Absolutely. And clearly we need better ways to treat it. Mayo Clinic researchers in Florida have made a discovery involving the most common type of lung cancer called adenocarcinoma. That could lead to better so-called targeted treatments if we can figure that one out. Joining us by telephone from Jacksonville, Florida is Dr. Alan Fields, a cancer biologist with the Monica Flynn Jacobi Professor of Cancer Research at Mayo Clinic. Welcome to the program, Dr. Fields.
Thank you, Tracy.
Thanks for joining us, Dr. Fields. So lung cancer still fairly common despite the fact that the number one risk factor, smoking, is at an all-time low. Fewer smokers than ever before.
Absolutely. And I think part of the reason is that there's probably a 20 to 30-year lag between the time that lung cancer begins to develop and when it's actually manifested as a diagnosis. So we would predict that if smoking rates continue to drop, that we will see a continuing drop in the rates of lung cancer as well.
Please explain the different types of lung cancer for us.
Absolutely. There are two major types of lung cancer. There's small cell lung cancer, which accounts for about 20% of diagnoses, and non-small cell lung cancer, which is responsible for about 80% of lung cancer diagnoses.
And that would be the same as adenocarcinoma?
Well, lung adenocarcinoma is a subtype of non-small cell lung cancer,
Okay.
and it's responsible for about 40% of diagnoses. So it's the major form of non-small cell lung cancer.
So small cell lung cancer has a worse prognosis?
Yes, that's correct.
Now, the most of the time when people are diagnosed with lung cancer, it has already spread elsewhere. Is that why it's so difficult to treat?
That's one of the major reasons, Tom, and that's often because lung cancer is often asymptomatic until the disease has progressed and has become metastatic.
Metastatic meaning spread elsewhere.
Meaning spread to the rest of the body, right.
And if it has not spread, there's potential to actually remove it surgically. But if it has spread, then how is it normally treated? Chemotherapy and anything else?
Yes, often chemotherapy combined most recently with immunotherapy, which is a relatively new form of therapy in which drugs are used to activate the a patient's immune system to actually attack the cancer from within.
So tell us about your research. What have you found? And by the way, how long have you been working on trying to find a better treatment for lung cancer?
Oh, this has been something that I've been working on for over 20 years.
Wow.
So we're definitely in this for the long haul. It takes a long time to identify new therapies that might be helpful.
And what's your new potential therapy?
Yes,
how does that
absolutely. work? So some time ago, we identified a gene that causes lung cancer, and it's called protein kinase C iota. And we have actually developed a drug that we are testing clinically in lung cancer patients, and it's showing some efficacy. Our most recent studies were really to try to identify whether PKC iota is responsible for all types of lung adenocarcinoma. And so we used mouse models in which we can genetically induce lung cancer in the presence or absence of protein kinase C iota. And what we found, somewhat surprisingly, is that cancers can develop, lung adenocarcinoma can develop even in the absence of protein kinase C iota. And this observation then led us to identify that there are human patients that whose lung cancer also appears to be independent of PKC iota.
So
Interesting.
it means that, oh, I love that. I'm going to try to break this down. But it means that even if you don't have the genes for it, and the genetics of the cancer are not correct, you still might be able to diagnose it that way?
Yes. So the implications of our research is that we can now classify different subtypes of lung adenocarcinoma to those that are likely to respond to our PKS inhibitor versus types that are unlikely to respond to the PKS inhibitor drug that we've developed. And in addition, what we've identified that in those tumors that are unlikely to respond to PKS-directed therapy, that there are other drug targets in that subset of cancers to which those tumors are more sensitive.
Now, tell us exactly what when researchers talk about targeted therapy, what exactly does that mean?
Yes. So classical chemotherapeutic agents are often drugs that inhibit the growth of cells, and they're not very selective for cancers. They just inhibit, and they're toxic, so they
That's why chemotherapy has so many side effects.
Absolutely.
It's affecting every cell in your body, unfortunately.
Exactly, depending on how quickly they replicate. So it often, you see side effects on cells that are rapidly dividing, such as those in the intestinal tract and the bone marrow. Targeted therapies, in contrast, are drugs that are targeted against specific genetic alterations that drive a particular tumor growth. So, for instance, we now know that certain tumors are driven by specific oncogenes, and oftentimes we've now been able to develop drugs that actually target those specific genetic alterations in those tumors.
How is this for patients that are listening? How is this going to affect patients potentially? Because we're still working in mice right now, but what is your hope?
Yes. Well, the first implication is that we can hopefully incorporate our ability to screen to predict whether a patient's tumor is likely to respond to PKS therapy or not, based on the findings that we found in mice. So that will help us to potentially stratify our patients in our current trials in which we're testing the PKS inhibitor, which will hopefully allow us to target our treatment specifically to those patients that are likely to respond and avoid that therapy for those patients who are unlikely to respond.
You know, this seems like coming at this from a circuitous sort of route, from the back door. Doesn't it sound simpler, or wouldn't it be simpler to be able to take a patient's cancer cells from a biopsy,
Yes.
put them in a petri dish, and pour different chemotherapies on there and figure out which one's going to kill the tumor?
That is one approach, and in fact, that's actually being taken. It's one of the approaches that is being developed. There are a number of issues with that, of course. Sometimes when you grow a tumor in a petri dish, it doesn't display the same properties that a tumor does in the patient's body. So oftentimes, drug sensitivities in a petri dish do not reflect the sensitivity to that same drug in the patient. In addition, it also takes a lot of time to establish these cancer cells and grow them in vitro in the laboratory and ask whether the drugs they respond to specific drugs or not. So there's often a delay.
Yeah. So this is obviously a tough nut to crack. You've been at this for 20 years. It sounds like you've made some progress, but one of those cancers that's just so far defied our best attempts to try to find better treatments, huh?
Yes, that's correct. And I think the strategy going forward is to not consider all of lung cancer as being a single disease, but rather that each of these subtypes, so we talked about the two major types of lung cancer, non-small cell and small cell, those characterizations, and then lung adenocarcinoma as a particular subtype of non-small cell lung cancer, those were all based on what a pathologist sees. So the pattern of growth of the tumor and so forth rather than on what the specific genetic alterations are that are causing that cancer in the first place. So now with targeted therapies, we're finding very good responses to specific subtypes of tumors, a certain subset of tumors based on a genetic alteration that produces a drug vulnerability. That is a vulnerability to a specific targeted therapy.
That is good news.
That's right. Well, we wish you a lot of success. Dr. Alan Fields is a cancer researcher at the Mayo Clinic in Jacksonville, Florida. Lung cancer still kills more Americans than any other cancer, but researchers at Mayo Clinic are hard at work on ways to treat it better. Thanks so much, Dr. Alan Fields.
Thank you very much for having me.